Good morning. Welcome to our first Let's Talk Parkinson's event of 2026, Skin Biopsies for the Diagnosis of Parkinson's. Today's program is brought to you by Parkinson's Community Los Angeles and our sponsor, CND Life Sciences. We're so fortunate today to have with us Dr. Tyler Cheung. I'm Judy Yaris. I serve on the PCLA board as vice president. For those who don't know us, we are a nonprofit that supports families living with Parkinson's through free education programs like this one, online and in-person support groups, social events, resources, and so much more. If you appreciate our work, please consider making a donation at pcla.org. Your donation is 100% tax deductible. So thank you in advance. We rely on your generosity to help us continue this important work. A few quick notes before we get started. We are recording today's event and we will be posting it to our PCLA YouTube channel as well as our pcla.org website. Both are incredible resources that contain informative and diverse presentations on improving your life with PD. Registrants will receive a link to today's presentation about a week from today. If you don't want to be visible, please turn off your video and stay muted. After the presentation, there will be time for questions, but you can also submit them during the presentation through the chat. Dr. Tyler Cheung grew up in New Jersey with his undergraduate education at Yale University in New Haven, Connecticut, followed by his medical training and neurology residency at Tufts University in Boston, Massachusetts. He finished in 2009. He subsequently did both clinical and research-based movement disorders fellowships at Mount Sinai School of Medicine in New York and Cedars Sinai Medical Center in Los Angeles. Since 2014, he has been practicing at Huntington Hospital, Southern California Neurology in Pasadena, with a focus on Parkinson's disease and other movement disorders. His particular interest is in deep brain stimulation for advanced Parkinson's disease, essential tremor, and dystonia, but also in early-stage Parkinson's disease and efforts toward accurate diagnostics and slowing of the disease progression. Please welcome Dr. Tyler Cheung.
Hello. Happy to be here. I'm Tyler Cheung, as mentioned. Greetings from sunny Pasadena. I was asked by PCLA to give a talk on this new test that has been making the rounds. It's relatively new, and we're actually, I would consider we're also ourselves kind of new at doing it, and I figured I would share some of our experiences and some of the thinking behind the test. I'll start by just going over, what is Parkinson's disease? A lot of you are probably already familiar with it, but I figured we'll just go over a brief definition just to set the stage. As you all know, it's increasingly recognized as a complex, probably much more complex than we realize, the neurodegenerative condition or even the family of conditions. There is some thought that maybe there isn't just one kind of Parkinson's, but many kinds. Classically, the presentation has always been described as a motor or a movement disorder. So subtle progressive symptoms of coordination, tremor, slowing of movements, and gait, and this all worsens over time. But as more and more people are diagnosed with Parkinson's and our understanding of the disease increases, we're realizing it's much more complex than that. It probably starts for many years before people actually have the movement symptoms. There's increasing recognition of significant other symptoms, including cognitive and neuropsychological symptoms, autonomic changes. I think a lot of you have heard the talks from some of my GI colleagues for Parkinson's and the gut motility, the microbiome, gut-brain axis, blood pressure fluctuations, urinary fluctuations, REM sleep disorders increasingly recognized as a very important symptom. So it's our understanding is evolving and more complex. What's in terms of a biological definition, that part we've known this for over 100 years of doing autopsies on patients with the condition who've passed away. As I said, it's a progressive neurodegeneration. So basically what happens is the brain cells affected with Parkinson's die off one by one. It happens very slowly over many years. On the right side, you see a cross section of the part of the brain called the midbrain. On the right side, you see a healthy midbrain with a healthy substantia nigra. Again, it's Latin for black substance. And you see the sort of very dark diagonal lines on that cross section showing a lot of cells with dark melanin staining. On the left, you see this cross section of somebody with Parkinson's disease. You see it's much more pale, indicating neuron loss and loss of those melanated neurons. It's estimated, again, it's always hard to tell for sure, but the estimate is that by the time somebody presents with the motor symptoms, the brain, being very resilient, has already lost 70% of the neurons in that area. So the brain is a testament to how much the brain can compensate. But by the time it presents, the disease is probably already even though the symptoms are silent, the disease has already been progressing. When you look under the microscope at these slides and on these brain cells, you see clumps of material which stains pink. This is what's called a H&E stain. And you see that round ball with that arrow, that's called a Levy body, after one of the pathologists who first described this back in, I think it was 1902 or so. Now, there's a lot of stuff in there. It's actually a bit of a mess, but the primary component of these clumps is this protein molecule called alpha-synuclein. So what is the alpha-synuclein protein? With a lot of these proteins, there's probably a healthy version that plays an important role in your brain cell. Exactly what, nobody's entirely sure yet. But everybody has synuclein in the brain, where when it's functioning properly, it probably is very crucial to the function of the brain cell. The problem is that if it gets diseased, it becomes alpha-synuclein. There's some additional molecules that get tacked on there. It doesn't fold into its proper shape correctly, and it becomes sort of a misshapen version of itself. So you can think of it as like the zombie version of the protein. It's part of a family of molecules known as the amyloid. So these are molecules with a specific definition of shape by the molecular biologists. And all you really need to know about that is these proteins tend to clump up into balls of debris or schmutz, and a lot of it is associated with disease. What the interesting to me, and this is just taking away from a very good presentation by Dr. Krause at Case Western at the annual conference this year, is that our understanding of the structures of these synuclein proteins have been actually increasing over the past few years as molecular techniques and science have improved. And so where we always assume, okay, there's Levy bodies and a synuclein, and that's shared amongst actually several different Parkinsonian symptoms. There's actually some variations in the molecular structure of some of these proteins. So just for example, on the leftmost of these four diagrams, you see the Levy fold that's typically found in Parkinson's disease. And next to it is the synuclein that's found in a related disorder called multiple system atrophy, which looks a lot like Parkinson's but has significant differences. The third one is for young onset Parkinson's. So these are people who have Parkinson's as early as their late 20s or 30s, sometimes even younger. And then on the right is again another variant that's been found. So our understanding of this protein continues to evolve. And just to I should mention also that Parkinson's is known as a neurodegenerative disease. Increasingly, another term being used to refer to these diseases are called proteinopathies. And these are all diseases that are characterized by slow degeneration of neurological function, things like walking, cognition, coordination, mood changes, things like that. These are all characterized by abnormal accumulation of these proteins in the brain, and gradually kill off the brain cells one by one. So probably the most famous relative to Parkinson's disease. So the Parkinson's disease is in the top middle, the Levy fold, but then you can sort of see there's similarities in structure to the tau proteins on the left, the most famous of which is Alzheimer's disease, another well-known neurodegenerative disease which affects your memory. Below are CBD and PSP, which are very Parkinson-like conditions but are considered distinct diseases. And then MSA, as mentioned before, and on the right are the prion proteins found in some animal diseases. Sometimes the closest human relation to those diseases is mad cow disease. So those are proteins for scrapie and some other mouse diseases as well. So there's increasing understanding of these proteins and how they're related, although, again, it's a very rapidly evolving field. This is sort of an interesting diagram from that same talk showing that how we think these diseases progress over time. And this all matches with maybe a lot of what we see in symptoms of patients. And maybe some of those in the audience may have maybe some personal experiences from friends and family. But in the very beginning, you have sort of subtle symptoms where the abnormal protein is usually near the bottom of the brain, but then it spreads slowly into the upper brainstem in the second diagram. And that's where people start getting all of the Parkinson's motor symptoms, unusual sleep symptoms, so on and so forth. Then as it spreads further in the limbic area, it starts to affect mood and emotions. And then when it gets further spread, that's when you have very serious cognitive and other symptoms. It doesn't always follow this pattern, but it's one way to try and organize how we think these conditions spread in the brain. One interesting discovery was also in patients with some of these conditions, and especially in Parkinson's, these proteins are not limited to nerve cells in the brain. You can actually find them elsewhere. The most famous of which I think a lot of you have heard the talk from one of my colleagues here, is that you can actually find them when you do biopsies in the GI tract, the stomach and the colon. If you biopsy the nerve cells, the autonomic nerve cells there, you can often find the abnormal synuclein. Saliva glands, certainly some body fluids, and also the skin. Now, just going back a little bit, when somebody has Parkinson's, how do we actually diagnose Parkinson's? The short answer is that it's what's called a clinical diagnosis. So rewind about 10 to 15 years ago, if somebody came to the doctors with Parkinson's, we couldn't offer them a blood test or like a swab like for strep throat or something like that. For those illnesses, there's a test, it's positive, we go, aha, you have like an infection, we give you the treatments. Parkinson's, we weren't at that point at that time. So typically when somebody comes with Parkinson's symptoms as doctors, we do a typical, the typical encounter would be we take a very careful oral history from the patient or caregivers, including what happened, what's the time frame, what medicines you've tried, prior medical conditions, so on and so forth. We do a very careful physical examination. Some supporting tests. These are not tests that actually tell you if you have Parkinson's or not, but can offer some supporting data. And then we review a specific list of criteria, and then we make a decision based on all of that, whether or not the patient had Parkinson's or not. Like I said, prior to like a decade or a decade and a half ago, there was no actual lab test for something like Parkinson's. This is just an example. This is a busy slide, but this is just to show that checklist or the criteria of things that we would look at to make a diagnosis of Parkinson's. As you can see, there's a lot of things to go over. You guys don't really have to memorize this slide, but we look for the presence of like slowness of movement, specific kinds of rigidity, specific kinds of tremor, pattern of presentation of body, and so on and so forth. And it seems like it's kind of vague, but it actually, for a while, I would say for clear-cut cases, we could reliably diagnose Parkinson's, but sometimes things are not as clear-cut. So just going for why create a test, and this slide is from, I borrowed it from the sponsor, CND Life Sciences. The number of Parkinson's cases and people living with Parkinson's is increasing. People are getting older. There's probably environmental factors. There's more industrial and agricultural components, which are a risk factor. More people are going into care. People are surviving longer. But then when you look at the Centers for Medicare Services data, a lot of folks with Parkinson's have limited access to care. So about 40% did not actually even see a neurologist. And I'm a movement disorder specialist, and I always feel like I'm very available, but it turns out maybe not as much because only not maybe less than 10% of Parkinson's patients are actually seen by a Parkinson's specialist. So, so if there are folks, personally, like those of us in the field, we feel like we can diagnose Parkinson's very easily, but if you're a practitioner who may not focus on Parkinson's and don't see as many cases, sometimes it's a little bit more difficult to do an accurate diagnosis, especially for a condition that's so complicated. And so there's estimated misdiagnoses for early stage disease, estimated about 30%. And so an easily and accessible testing may overall improve treatment plans and reduce delays in care, get people to where they need to be seen. And also just knowing more about the disease earlier on improves disease monitoring and also for medical research. So this is 2026. So the currently clinically available testing is, you guys have probably all heard about the DAT scan that was approved by the FDA in 2011. That's probably a subject for a whole other talk, so I won't really go too much into that. And then probably over the past year or so, maybe longer than that, but there's a skin biopsy developed by this company in Arizona, CND Life Sciences. I think the initial studies were first done on the East Coast, I believe, in Beth Israel Deaconess Medical Center in Boston. The important thing is it was approved for Medicare approval, I think, late in 2024, which made things much more available to a lot of folks. The current status is actually not fully FDA approved yet. But the FDA considers it as a laboratory developed test, and it's available through what they call a CLIA program. They gave it FDA breakthrough device status late last fall. So it's not yet fully FDA approved, but it looks like it's on the way to being there. But the important thing is that Medicare approved insurance coverage in late 2024. So they feel like it was worth it enough to cover this test for patients. I'll just briefly mention there's other tests in the pipeline which test spinal fluid and blood samples, RT-QuIC and seed amplification assay. Those are still considered experimental, so not quite ready for clinical testing as of yet. So it's typically done in research studies. What is the test? So typically it's done in 3 spots. We do it on the one up in the shoulder, the skin kind of in the mid to distal thigh, and also in the mid calf. So that's a quick diagram where in the body we would do the tests. Typically done in the bedside. The total time of the biopsy takes about 10 to 15 minutes, so it's very quick. On the right side, you see sort of a brief diagram. In hindsight, I probably should have asked some volunteers in the clinic to see if they wouldn't mind having some photos taken, but unfortunately, I don't have that. So this is some diagrams from CND Life Sciences. There's a very small skin poke. It's about 2 to 3 millimeters wide, so not very large at all. They put in a little bit of a cylindrical core sample that's pulled up and removed. The tests are then mailed to the laboratory, and turnaround time is about 3 to 4 weeks at the moment. And it's usually tolerated pretty well. I haven't had anybody say that it was especially painful or anything like that. Typically, local anesthesia is used. Some people prefer not to, but most people come in with some lidocaine, and we just go ahead and inject that before we actually do the biopsy. This is just a sample of what they do in terms of how to test for the abnormal synuclein. So on the left, you see this is a general what I call a PGP 9.5 stain. So these are samples that are under the microscope. On the left, the green stain just stains for anything that's a nerve cell. So the PGP 9.5 stains for anything in the microscope that is an actual neuron or a nerve cell. On the middle, you see the PSYN staining. So this is actually an antibody that's hooked up to a substance that glows red. And so the antibody picks up on the abnormal phosphorylated synuclein, the alpha-synuclein. And so if it's present in a cell, in the nerve cell, it glows red. And they merge everything together. And if they see this sort of orange shape, it's considered a positive test. Yeah. How well does it work? So before I go into that, I'm just going to go over some brief measures of how we determine how good a test is. So the first one is this called the sensitivity. So if you take 100 people who all have Parkinson's, that's the percentage um, of people that the test can pick up. So if everybody who has disease and do the test on all the people, this is the percentage that will be positive. So, versus the specificity is if you take 100 people without the disease, then that's the percentage that will have a negative test. So measures that basically these are measures of how accurate a test is. The big trial that measured the performance so far was done in 2024. It was published in JAMA, one of the medical journals. So they enrolled about 343 people. I know the text is a little bit small, but which ended up about breakdown of about 217 folks with some kind of Parkinson's disorder, and about 120 folks with actually no disorder. So, how well did it do? So overall, in detecting any kind of Parkinsonian syndrome, the sensitivity or the chance that the test would be positive if you actually have the disease is 95.5%. For tests, I would say that's actually pretty good. When you can see the breakdown, Parkinson's disease, the accuracy was about, or sensitivity is about 92 point, or about 93%. For some of these other atypical conditions, which are much more aggressive conditions, and presumptively there's actually a lot more abnormal protein, the accuracy was as high as about, or the sensitivity was as high as about 98% for multiple system atrophy, about 96% for dementia with Lewy bodies. That was the condition that Robin Williams had, and so on and so forth. For folks who actually did not have the disease, the positive rate was about 3.3%, so about a 96.6% specificity. Now, in comparison to the DAT scan, you can sort of see, I just threw the numbers up there. The problem with the DAT scan is that there's not really great measures on the accuracy. And the accuracy kind of depends very highly on who the radiologist is and who the radiology center that performs the test. So there was one trial where the sensitivity for the DAT scan was about 78%, and another trial where the sensitivity was about 97%, but it really depended on who was reading the DAT scan. The DAT scan also, but however, the specificity for the DAT scan was always around 97%. So just gives you an idea of what the accuracy rates of this test is. Again, that might change as more and more people have the tests, but these are the numbers so far. How did the test actually provide any useful data? So there's one study that was also done at Beth Israel Deaconess where they retrospectively looked at what happened when people it was a Parkinson's movement disorders clinic, and people presented at clinic with Parkinson's. And on the left, you see a chart that showed any change in diagnosis or treatment after the test. And the text might be a little bit small, but the scenarios where they would do the test would be if somebody came in with Parkinson's or he had any of these suspicious features. So people who were also taking a psychiatric medicine and they were the medicine was causing the symptoms instead of actual Parkinson's disease. People with Parkinson's who did not respond to Parkinson's medicine. People with Parkinson's who had an action tremor instead of a resting tremor. People with very prominent early cognitive impairment, very prominent blood pressure swings, or very prominent early gait involvement. So features to suspect that maybe it's not plain vanilla Parkinson's. And it turns out overall changes in clinical decision-making happen in about over 3/4 of patients. There are diagnosis changes in about 2/3 of patients, and so on and so forth. And actual medication changes in about over half of patients. So it actually seems like the test is contributing to the day-to-day practice of neurology. I'm just going to briefly go into our experience here at Huntington. So we run I'm part of, so my clinic is, I would say, I would describe it as a movement disorders clinic. I would say 3/4 of the patients that we see are Parkinson's or some other movement disorders. We see other things as well, but that's primarily my focus. We started doing this test last January after we received notice that Medicare, I guess Part B was starting to cover the test. So we made inquiries. We actually met with some CND folks at the Movement Disorders Congress that happens annually. And I wasn't really expecting much because I guess maybe I was cockier back then, and I thought, oh well, I didn't really need this as a practitioner to diagnose Parkinson's, and I didn't think people would like to get poked by anything, and so on and so forth. So I thought, okay, well, maybe I would only do 3 to 5 tests in the coming year. Turns out it was much more popular than I thought. So I just checked our records. We probably did about 50 over the course of 2025. When we presented it and we mentioned it was a possibility, people actually really liked the idea and they wanted to test and they asked for it. Also, when folks come in with like one of these suspicious features and you're worried it's an atypical diagnosis or something like that, then it actually proved to be very useful. Diagnosis that we typically involve people with Parkinson's disease, people that we suspected with these atypical Parkinson's syndromes. You may or may not have heard of them: progressive supranuclear palsy, multiple system atrophy, cortical basal degeneration, Lewy body dementia, and also a lot of folks who with long-standing psychiatric diseases but were having movement disorders. And we were worried either was it Parkinson's or was it a side effect from one of their medicines. Overall impression, this is my non-scientific kind of personal impression, is I felt that the results generally aligned with what I expected. Folks with Parkinson's generally had positive tests. Folks or with MSA or Lewy body disease also generally had positive tests. Folks, a lot of the psychiatric folks ended up having negative tests, which, again, this is what we expected and built a lot of confidence. I will note that there are 2 cases that I swore that it was, to my eye, was very classic early stage Parkinson's disease. That's the type of symptoms that I saw when I was doing a fellowship. And I thought for sure slammed on Parkinson's, and they were negative. The question then became what to do, because the patient still had the symptoms, and ultimately you have to go by what the symptoms are. So I think for them, I told them, well, it's negative. It could be they just didn't pick it up. It could be that maybe it's not Parkinson's, but we're still monitoring them just in case. Typical scenarios where people would get the biopsies. So a lot of folks would be early stage Parkinson's. Again, it's a very weighty diagnosis, especially if you're hearing it for the first time as a patient. And so a lot of patients do want confirmation, and just having the positive test really, granted, it's not like great news, but like I think for them the uncertainty, there was still some uncertainty, and they didn't like the uncertainty without the test. So that it proved to be very popular for a lot of folks who were just getting diagnosed. Some people came to the office as second opinions. Another physician wanted me to take a look, and the patient had very aggressive progression of symptoms. So patients became very severely impaired over 1 to 3 years, and we were worried there was something else going on. Again, very early gait and falls, earlier than expected for a Parkinson's diagnosis. Prominent early cognitive symptoms, and also lack of medication response. Also, we had a lot of folks who had psychiatric conditions and they were on medicines for many, many years, but then started developing symptoms like a tremor or trouble walking or involuntary movements and so on and so forth. And that was another scenario where we typically do this. So this is typical our experience over the past year. Tolerability. Like I said, typically we would order a vial of lidocaine, so we did basically before we actually do the poke, we would inject that under the skin. When we do that, the patients don't really even feel the biopsy. I mean, I would say the injection of the lidocaine probably hurt a lot more than the actual biopsy. A few patients actually decided to proceed without anesthesia, but even with that, they felt that the discomfort was mild at most. So they all said it was not too bad and was better than they expected. No major instance of bleeding or infection, and the healing time roughly about 2 to 3 days. So there's another patient that came in a couple days later for a follow-up. We looked under bandages. The skin was more or less already healed. So parting thoughts. So again, a lot of this illustrates that Parkinson's is and continues to be a complex disorder, especially as the science behind Parkinson's continues to improve. And synuclein skin biopsies over the past year are proven to be a valuable diagnostic tests, particularly for murky clinical situations where things are not entirely sure. But besides that, it also is much more popular than I expected for folks that we think have Parkinson's, but just wanted confirmation. Test results are proving useful in determining treatment decisions and prognoses, not just for our clinic, but in other centers as well. The test itself is easily accessible and well tolerated. We haven't had any major coverage issues with insurance, and patients seem to not mind the test very much. And again, patients appreciate the certainty and clarity that the test provides. The other thing that was interesting is that for a while, there's always been research in synuclein, but I think in the past 5 years or more, I think our understanding seems to be increasing much more rapidly than before. And the hope is with this increased understanding of alpha-synuclein and its role in disease, maybe there will be more treatments, particularly disease-modifying therapies. I'll just give a brief shout out. We are hoping to start a trial for one particular medicine against alpha-synuclein. And so I'm hoping some of these efforts, there's actually, I think, in the Congress, they mentioned several other candidates in the pipeline, which are not quite, I think they're still in the works, but the hope is that I think since they discovered carbidopa-levodopa in the late 1950s, there hasn't been a medicine that slows down the progression of Parkinson's or even stops it completely. And I'm hoping this will actually change in the next few years. And so that's what I have in terms of presentation. I'm happy to open it up for questions. And if you do think of a question later, just take down my email. I'm happy to correspond via email.
Thank you so much. That was so interesting. And also, I'm hoping now that we can go on to Q&A. And participants, you can put your question into the chat, and I will go ahead, either myself or Dr. Cheung will be able to see it, and we can respond. I don't know if we have anything in there at the moment. We don't, but I do have a question for you. I was thinking, how did you diagnose the atypical Parkinson's, the MSA, PCP? How did you do PSP rather? Were you able to diagnose it prior to this test?
Okay, so the question is that for these atypical conditions, how would you diagnose it? So the short story is before the test, it would be clinical diagnoses. So these would be Parkinson's patients who either they were diagnosed with Parkinson's, but their clinical course was much more aggressive than expected, or they either they were already diagnosed with Parkinson's or came to the office completely new. And then you look for a number of, I would say, red flags. So like I mentioned, any sort of very early, for MSA, typically be any sort of, for all of them, I guess, the big red flag is that early falls within the first year or two of diagnosis. Parkinson's patients do have walking problems, but in our experience, the falls usually happen after several years versus somebody just got diagnosed and they were normal a year ago, but then they had 5 falls, 10 falls, even 20 falls, then that's the biggest red flag. There are certain exam findings which contribute. So patterns of where patients are rigid, certain eye movement features, again, early cognitive features. I think, for example, like Robin Williams, I think if you read through what his wife wrote in neurology, it was very rapid decline of mentation. So these are all like sort of features that sort of raise alarm bells. And in the past, it would just be like a checklist. So for MSA, it would be sort of very midline axial rigidity, early falls, and blood pressure. PSP, again, early falls with relatively normal blood pressure, but abnormal eye movements, and so on and so forth. Now, when they look at the accuracy of these things, it probably wasn't great. And so this is where I think the test might become more useful. The tests like this and maybe other ones as well, because I remember when I was a student, I was reading through there. Columbia, considered like maybe at the time one of the top movement disorder centers of the world, they looked at the correspondence of what the physician thought it was, the physician clinical diagnosis, and then what the pathologist thought it was on autopsy, and turns out that the physician was right about 55% of the time.
Oh, okay.
So we all tend to get a little cocky as physicians. I'm sure in other professions and activities as well. But it was kind of a sobering look, and we always need to be a little bit humble and just realize that things can always be a little better. And then actually having an objective test is pretty valuable. So
I can see that. We
yeah.
have some questions. June Saffron is asking, does the test work for adult children of patients to prepare them for the future?
So the question is, so does the test work for, I guess, children of patients with Parkinson's? Um, that one I don't know. It kind of depends, I guess, what the like how old you are and what the age difference is. I do know that CND is running or sponsoring some trials in terms of what they call prodromal symptoms.
Hmm.
Um, but I don't really have the latest data on that. Um, my thoughts on that would be if it's done too early, it might not pick up anything. Like before the abnormal protein starts turning abnormal, it might just not be able to pick it up. Um, so I would say if the age difference, I mean, typically it'd be like 10 or 15 years or 20 years age difference between from adult children. Um, you might not be able to pick it up. I think if you're about the same age as your parents when your parents got the disease, then maybe, but it might be an area for more research.
Oh,
Um, and But it's an interesting question. The one thing that might be interesting is to see, well, how accurate is it for I know there's a study that they're going to come out with for REM sleep disorder, which is considered a
mhm.
pre-Parkinson's symptom.
Right.
And I think the answer to that question depends on what the results for the REM sleep behavior disorder. If it's done too early, does the accuracy go down?
Oh, interesting. Okay, thank you. Another one from Jim Lee. Does the test tell you whether it is PD, MSA, LB, or is that still done clinically?
Okay, so the question is, can a test distinguish between these different Parkinson's diseases? Parkinson's disease, MSA, and LBD are these atypical Parkinson's conditions that we
Mhm.
mentioned before. Can a test differentiate that? The answer is a little bit. Um, I think what they found was that for MSA and Lewy body disease, there's a much higher level of the alpha-synuclein, so the abnormal protein burden is much higher. So what they're finding is that there's 3 skin samples. A lot of times the Parkinson's disease patients will have maybe 1 out of 3 samples positive versus the MSA and the DLB patients will have like all 3 samples very positive. It might not be enough to determine one or the other. So I think the ultimate diagnosis still will depend on clinical diagnosis. So um, if something is very, very positive and people have all the features of MSA, then I think that's what makes the diagnosis. Ultimately, even with a test like this, the ultimate diagnosis depends on what the patient is actually having and the reality for the patient. So, um, but there are subtle differences in terms of, I guess, how much protein they see on the test between these 3 conditions.
Mhm.
I think also the Parkinson's tends to favor more abnormal protein higher in the body. So they think it's the spread maybe from the head down to the toe. So I think there was some mention in some of these papers that for Parkinson's patients, there tend to be more protein seen in the shoulder sample versus down in the leg.
Interesting. Okay, another one from Ellen Redding. Can POTS indicate a Parkinsonian diagnosis? And POTS, especially with multiple falls and REM sleep disorders.
Okay, so the question is POTS potentially an indicator, like an early symptom of some sort? I'm going to preface this by saying POTS has a lot of definition. So it stands for postural orthostatic tachycardia syndrome. And the condition tends the definition is tended to snowball, but like as a baseline, let's just say it's a condition where that if you change position or stands up too quickly or other triggers, your blood pressure, your heart rate tends to drop drastically, and that can potentially lead to a lot of weakness and lightheadedness and fainting spells. I think it potentially can be an early sign of some of this, especially depending on the age. Now, a lot of the one condition where you'll be most worried about where that's the presenting symptom
Mm-hmm.
would probably be multiple system atrophy, which is one of these atypical Parkinsonian syndromes. Um, for Parkinson's, I think it potentially could be what's called a prodromal symptom, especially if people are trying to come up with an algorithm to detect early, like pre-motor Parkinson's. So Parkinson's before you actually get like things like tremor or the stiffness
Mm-hmm.
or the discoordination and so on and so forth. Um, I think the biggest symptom so far has been REM sleep disorder. There's some GI stuff as well that with like the delayed gastric motility, that sort of thing, the loss of sense of smell. And also, I think dysautonomia is part of it. I think I've had at least one or two patients where they actually had what they call orthostatic hypotension. They tend to drop their blood pressure very easily
Mm-hmm.
for maybe even 5 or 10 years before they came in with Parkinson's. So now, statistically, if you just have one out of those symptoms, it's going to be hard to tell. But if you have two or three of those symptoms, then I would say I would consider that patient to be at risk for developing like motor Parkinson's. And I think as more as these studies come out, I think they're doing these studies on REM sleep disorders. There may be the CND people might be able to weigh in more on that, but there may be other trials in the works in terms of looking at whether these results are positive for some of these other features. But if there's enough risk factor, then there might be a reason to do early testing.
Mm-hmm.
Um, And I guess the goal is that if you can catch it early enough and there's some kind of like disease modifying therapy, then maybe that can make a difference earlier on.
Mm-hmm. So another question that I have is, are you recommending this to most of the patients, to all of your patients that are coming in, or suggesting it to all of the patients that you're seeing, or is it something that the patient needs to ask you about?
Um, I've actually started to so like when I see a patient for the first time, I try to sort of give an overview of like what the disease is, available treatments, and also the diagnostic options. I've actually started to so I'm actually mentioning it as an option, but a lot of times if it's very early disease and they're not having a lot of symptoms, I would tell them it's purely elective. They don't have to do it, but it's available if they want to do
Hmm.
it. Now, if somebody comes in and there's some of these concerning red flags that we talked about earlier, that's well, we're going to have to do it. So,
Hmm.
but I think I always at least mention it. It's become it's relatively easy to do and it's reimbursed by insurance and it's I think it's becoming such a useful test that
Hmm.
I at least mention it.
Okay.
So
And we have another question. Pamela Downiger asking, is the test accurate after taking levodopa regularly?
okay, so levodopa is the medicine typically for Parkinson's. The answer is yes. The reason being is that carbidopa levodopa is what's called a symptomatic treatment. It helps with the motor symptoms,
Hmm.
and very dramatically so, but it's not what's called a disease modifying treatment. So it doesn't actually affect the amount of synuclein at all. So yeah, the patients can be on levodopa and still take the test.
Okay. I know a lot of people in our group have discussed this particular procedure, and some of the conversation is, well, I've already been diagnosed with Parkinson's. Why would I want to do
Yeah.
this test? So I guess that's the big question.
Yeah, the big question is if you're already been diagnosed first, I think if you're diagnosed with Parkinson's and the symptoms are what the physician expects them to be, and then the response to medicine is pretty stable,
Hmm.
I would actually say there's probably not a great reason to take the test unless it's you're part of like a research trial or something like that.
Hmm.
I think where it becomes important is like the early people are just diagnosed or people with any of these red flags,
Hmm.
like concern for the atypicals or some other causative factor or something like that.
Hmm.
I would say people who've we've already in the clinic and they've been stable for a few years and they're on the medicines or we typically don't really offer it to them. I mean, if they wanted to, we could do it, but
Hmm.
there isn't like a great reason to put them through it's very mild discomfort, but it's still discomfort, you know.
Right.
But I would say, yeah, there's the specific scenarios where we would do it would be early disease or any sort of atypical exam or findings that we're concerned about. So,
Hmm. So if someone felt that their symptoms were really progressing very quickly or
yeah,
more than they expected, you might want to suggest this. Would that be an opportunity to do it?
yes, yeah, especially if it's more aggressive than they expect and that raises the possibility it could be one of these atypicals,
Hmm.
we would offer the biopsy.
Okay.
Yeah.
That's very helpful. Thank you.
Yeah.
Um, Jim Lee is asking, can you talk a bit about GI biopsy data?
Um, can I help, the question is, can I talk about GI biopsy data? There is so this I know this one I probably would have to refer to my colleague. Um, so I'm aware of the biopsy data. There's some labs that have done biopsies on autonomic nerves in the gut, and they've been able to find the abnormal synuclein there. Um, there's also clinically folks with Parkinson's tend to get constipation basically, so delayed gastric emptying, and probably for several years before they get the symptoms. And there's other interesting features, like for folks who actually have had a vagotomy, where their vagus nerve, the nerve that runs from the brain down to the gut, has been cut, actually seem to, as a population, have like a lower risk of Parkinson's.
Hmm.
Um, so exactly where they stand, I think there was a couple talks. They're starting to look at the microbiome and a number of all these things. But we actually have a colleague in the office who I think may or may not have given another talk with you guys, but
Yes, Dr. Elnashek. Yes.
and he can probably go into that way better detail than I can, just because I'm not a gastroenterologist. But
Right.
there is very clear GI involvement especially in early stage Parkinson's and also in mid to late stage Parkinson's, where the GI symptoms sometimes interfere with medication absorption and nutrition and that sort of thing.
Yes. Jim, I'll suggest to you if you go to the PCLA website and go through the archives, you will find Dr. Elnashev's presentation on microbiome. He's actually done a couple for us at several different times. So check it out. I think you'll get some great information there. Okay. Any more questions? I mean, I feel like I have a million questions that I could ask, but I found this to be so interesting. I love that we are able to, we've come to a place that we're really starting to identify different ways of seeing Parkinson's, where it's coming from, how it's progressing. And this just looks like another tool that's going to give the movement disorder specialists so much more. And
I agree, and I think it may actually trickle down to people who are not movement disorder specialists, just because it's inexpensive and it's not very hard to do. And I can very easily seeing like a nurse practitioner
Mhm.
or somebody in a rural clinic um, or in a general practitioner's office doing this sort of thing.
Right, because I think a lot of people start off with neurologists, so
Yeah.
wondering if that's something that will trickle down that way, that maybe neurologists will just automatically recommend it. It'll be
Yeah.
interesting to see. Thank you so much. This was so interesting, so informative. We've already had someone in the chat thanking us, saying they learned so much from it, as I did. And I really think it was great. Thank you, Dr. Cheung. And a special extended thank you to our sponsor, CND Life Sciences. Thank you for making this possible with us. If you enjoyed today's program, please visit pcla.org and make your donation today. By donating to PCLA, you can join us in our mission to improve the lives of families in our community living with Parkinson's. You can find our contact information on the button at the bottom of the screen. PCLA is a nonprofit and all donations are tax deductible. Also, don't forget to check out our website. We have so many exciting upcoming events for February, March, and the rest of the year. And I just want to thank you all for joining us today. This was really great. Thank you, Dr. Cheung. Very, very interesting presentation. Greatly
My
appreciated.
my pleasure, and I'm happy to be here. So.
Thank you.